Uh, Good morning.
Good morning.
Today we are starting a new session that is surgical audit. Surgical audit is a very important part of academic exercise, wherein you review your work done in the past 1 month, and out of that we may have some lessons being learned from this discussion. We will discuss the patient you are treating over a period of 1 month, how they are being treated, what is the outcome. If there is a mortality, we would like to discuss why the death has occurred, whether this death could have been averted. So this will be an exercise for each unit, and each unit will present the audit, and we have some discussion at the end of this presentation. So we started the surgical audit for Unit 3 of General Surgery at MR Hospital. This will be presented by Dr. Nitesh Pradhan. Nitesh,
Yes.
you can start.
Yes, sir. Good morning, respected teachers. I am Dr. Nitesh. I'm going to present surgical audit for month of April 2022 under Unit 3 General Surgery. Unit under Professor Dr. M. Makhanlal Saha, Dr. Rahul Naskar, Dr. Pranamita Chakravarti, and postgraduate trainees. Sir, some technical issues are wait.
Sort it out.
Summary. Total OPD days in the month of April was 7. Total admission days 8. Total OPD in the patient was 415. Total number of elective OT days were 4. Total time in the OT taken was 16 hours 45 minutes. Total number of minor OT days 4. Total number of mortalities were 0. Elective admission was total was 20 out of which 8 are male and female were 12. Emergency admission 9, male were 4 and female 5. Elective operation done was total 10 and male 4, female 6. Emergency operation total 4 and male 2 and female. Mortality was 0. Morbidity 2, 1 female, 1 male. Elective admissions, patient with chronic calculus cholecystitis. 1 patient was admitted, patient was female and underwent a laparoscopic cholecystectomy. Chronic calculus cholecystitis, total and the management given was open cholecystectomy. Total were 3 and 3 are female. Inguinal hernia, management given Lichtenstein tension-free mesh repair, mesh hernioplasty. A total 2 male patients. Distal cholangiocarcinoma with a feature of obstructive jaundice, palliative care given. Female patient. Periampullary carcinoma, patient was operated, Whipple's operation, male patient, and foreign body in the right foot, done and exploration under C-arm, male patient. And port site recurrence from the epigastric port, true cut biopsy was done, and medullary CA thyroid in post-op case of right thyroidectomy. Completion thyroidectomy with central neck node dissection was done in the female patient. Gastric outlet obstruction in case of CN stomach. Conservative management was given, patient took LAMA. Incisional hernia, post-hysterectomy, mesh hernioplasty was done. Chronic right breast abscess, IND plus biopsy from the wall of the abscess. Chronic wound infection, post LSCS, sinus tract excision was done. Left leg cellulitis, debridement and conservative management was done. CA colon, right hemicolectomy done in the following month. Sebaceous cyst, excision, cystic swelling over the scalp, excision was done. An ovarian and mesenteric cyst, ovarian cyst excision with left oophorectomy done in following month. Total elective admissions were 20, out of which 8 male and 12 female. Emergency admission, right gluteal abscess, IND was done. Acute appendicitis, 2 patients, both underwent open appendicectomy. Gallstone pancreatitis, conservative management was given. Surgical emphysema, left-sided chest wall following RTA, conservative management was given. Left spontaneous pneumothorax, ICD placement was done. And Mittel-Simers syndrome, conservative management. Appendicular lump, conservative management was given. Acute cholecystitis, 1 patient, conservative management was given. Total 9 out of 9, 4 were male and 5 were female. Minor OTs, excision of sebaceous cyst, total 2 were done. 2 male patient. ZX procedure for ingroin toenail, 2 were total 2, 1 out of 1. Out of 2, 1 were male and 1 is female. 1 was female. IND 3, total 3 out of 2. 3, 2 were male and 1 were female. Then intralesional triamcinolone injection in ganglion, total 2 patients, both were female. Debridement under local anesthesia, 1 patient, and the patient was male. Total 10 elective minor OTs. Out of 10, 6 were male and 4 were female. There were total 2 morbidity seen in the month of April. One is intra-abdominal pelvic collection in case of Whipple's operation, post-op Whipple's operation, and bile leak in case of open cholecystectomy. Mortality was 0. Morbidity 1, 58-year-old gentleman admitted and diagnosed with periampullary variety of ampullary carcinoma. He was operated. Procedure was Whipple's operation and doing well. Drain removed at POD 6. On POD 10, patient developed abdominal distension, fever and chills. Patient was subsequently improved and discharged. 40-year morbidity 2. 40-year-old lady admitted with diagnosis of chronic calculous cholecystitis and was planned for open cholecystectomy. Intraoperatively, patient had mild bile duct injury and was repaired subsequently. On POD2, drain output was 200 ml containing bile. Following injection octreotide and hyoscine was started. From POD 8, bile output has subsequently reduced 200 ml. Thank you, sir.
Okay. Any question from anybody? Nitish, what is your MRCB report of that patient?
Yes, sir. Sir, it was only they given, sir, collection at hepatorenal pouch, sir, GB fossa, sir.
What about the
sir, bile, sir, they comment, all they said there is no leak from bile duct, sir, common bile duct or anyone.
No, common bile duct main trunk is thin.
Sir, they said no filling defect and no main bile duct is intact.
Okay. So it might be a sectoral duct that is getting into.
Yes, sir.
Okay, we pass on to audit of unit 1.
Yes, sir.
Dr. Milind, you can share your screen and present.
Yes. Thank you, sir.
না না ঠিক আছে বাইরে এটা এখানে বাইরে করে কেউ কেন ইউজ করে যেখানে আছে কেউ ইউজ করে দিলে করে দেবো হ্যাঁ আমি রেগুলার করি তো
So may I start? Good morning. I'm presenting the surgical audit for the month of April 2022 under Unit 1 of General Surgery, unit under Dr. Kuntal Chakravarti and Dr. Siddharth Mishra. In summary, the total number of OPD days was 6 and the total admission days was 7. The total number of OPD patients were 504. Total number of elective OT days were 3 and approximate time in the OT was around 12 hours. Total number of minor OT days was 6 and the total number of mortalities was 0. Now, there were total of 11 elective admissions, of which 8 were male and 3 were female, and the number of emergency admissions were 18. Elective operations were 11 and emergency operations were 7, of which 4 were male and 3 were female. There was no mortality and no morbidity. Among elective admissions, 3 patients, or total 2 females and 1 male, was admitted with a diagnosis of chronic calculous cholecystitis and who underwent open cholecystectomy. 1 male patient was admitted with the diagnosis of gastric outlet obstruction with peptic ulcer disease and underwent truncal vagotomy and gastrojejunectomy. 1 patient had a bilateral inguinal hernia and underwent bilateral Lichtenstein tension-free mesh hernioplasty, while 3 patients underwent who had unilateral inguinal hernia underwent the same procedure on the unilateral side. 2 patients had a hydrocele and went for an aversion of SAT, and there was 1 child who had diagnosis of phimosis and went for circumcision. Coming to emergency admissions, the 1 patient was admitted with acute retention of urine with UTI and managed conservatively. 3 patients and 3 females were admitted with the diagnosis of acute cholecystitis and managed conservatively, and 1 patient was admitted with the diagnosis of chronic pancreatitis and managed conservatively. 1 female patient was admitted with the diagnosis of strangulated paraumbilical hernia. She underwent exploratory laparotomy, omentectomy, along with wedge dissection of the ileum, and ilioileal anastomosis was done. 3 patients underwent emergency open appendicectomy, of which 2 were female and 1 was male. 2 patients underwent incision and drainage for perianal abscess. Patients admitted for pain abdomen, pelvic inflammatory disease, RTA, and head injury were managed conservatively. 1 patient was admitted with Fournier's gangrene, and debridement was done for the said patient. Among minor OT procedures, there were 2 excision of sebaceous cysts, 1 excision of lipoma, and there was debridement done under 1 debridement done under local anesthesia. There were 4 cases of incision and drainage of acute paronychia, 3 excisions of papilloma, and there were 2 cases of Zadek's procedure for ingrown cornea. There was no morbidity or mortality that was noted during the month of April. Thank you.
Milind, what did you do with the hernia part? In strangulated hernia? You done a resection. What about the hernia management?
Sir, in this paraumbilical hernia, sir.
Yeah.
Sir, segmental resection was done, sir, and the ilioileal anastomosis was done.
No, Milind, for the hernia, for the management of hernia, what we did?
Sir,
Did you put a mesh or did I?
no, sir. Mesh was not put, sir.
Primary repair.
Primary repair, anatomical repair was done, sir.
Okay. You see, morbidity you include everything. Try to understand. Any post-op deviation like surgical site infection, prolonged ileus, any fistulas, anything. This is the
Sir, you're muted, sir. Sir, you're muted.
the point is in the morbidity we try to discuss all the deviations of normal recovery so that you can understand what may be the possible complications and what may be the treatment for those complications and how do you start treating those patients. Okay, so don't comment anything. Any SSI, any SSI. Okay, any SSI and any suppose patient having a prolonged ileus. That is also post morbidity. Okay, so we will discuss what is going the deviation from the normal recovery and how did you manage that. And if there is a death, subsequently if there is a death, give a chronology. Chronology means with what patient was admitted, what happened next, what did you do, how the patient deteriorated, because you don't have postmortem.
Yes, sir.
We don't have postmortem. So what we're going to do is you want to just discuss what is happening grossly and what you have done to avoid that.
Okay, sir.
Okay.
Yes, sir.
Okay. Any other question? So we pass on to the
Then you have
next.
mentioned the RTA.
Yeah.
Simply an RTA in the emergency admissions. What is that RTA? Don't mention it is an RTA. Be more specific about that.
Okay, sir.
Yeah. So pass on to the next. You need to Dr. Omkarnath, please share your screen and present.
Good morning, sir. I will present surgical audit for month of April under Unit 2, unit under Sir Dr. Jaideep Roy and Dr. Abhishek Bhomik. Summary: total OPD days was 7 and total admission days. Total OPD day was 6 and total admission day was 7. Total OPD patient was 409. Total number of elective OT days was 4 and total time in OT was 12 hours and 25 minutes. Total number of minor OT days 6 and total number of mortality was 2. Now coming to total elective admission was 17, among which 9 was male and 8 was female. Total emergency admission was 15, among which male was 6 and 9 was female. Elective operation 10, among which 5 was male and 5 was female. Total 5 emergency operation, 2 was male and 3 was female. Mortality was 2, among which 1 was male and 1 was female. There is no morbidity. Elective admission, one male patient was admitted with diagnosis of chronic calculus cholecystitis, for which laparoscopic cholecystectomy was done. One female admitted with chronic calculus cystitis, for which open cholecystectomy was done. One child admitted with congenital inguinal hernia, for which herniatomy was done, and one male patient admitted with bursal cyst over right lateral malleolus, for which excision was done. and 3 patients admitted with acute cholecystitis, for which conservative management was done, among which 1 was male and 2 was female. One female admitted with right gluteal abscess, for which incision and drainage was done, and 1 female admitted with recurrent appendicitis, for which open appendicectomy was done. One female patient admitted with admitted with colonic mass under it was under evaluation, which but patient lost to follow up. One female patient was admitted with incisional hernia, and for which mesh hernioplasty was done. Two child admitted with phimosis, for which circumcision was done, and one male patient admitted with necrotizing pancreatitis, for which conservative management was done. One female admitted with right palmar abscess, for which incision and drainage was done, and one admitted with ureteric coli, for which conservative management was done. Now coming to the emergency admission. One male patient admitted with alcoholic pancreatitis, for which conservative management done. Two male patient admitted with acute appendicitis, for which open appendicectomy is done. One male patient admitted with large bowel obstruction, for which conservative management was done. And one patient admitted with came in emergency with acute retention of urine with endometrial carcinoma and liver mets, for which foliage catheterization was done, but later succumbed to death. And 6 patients admitted with acute cholecystitis, for which conservative management was done, among which 2 was male and 4 was female. One incision and drainage done. One female admitted with multiple rib fracture with hemothorax, left-sided hemothorax, for which ICD was done. Minor operations. The excision of sebaceous cyst. There were 3 excision of sebaceous cyst, among which 2 was male and 1 was female. ZX procedure for ingroin toenail, and 2 procedure was done, 1 for male and 1 for female. 4 incision and drainage, among which 2 was male and 2 was female. One patient undergone granuloma excision, and 2 patient underwent Kenacort injection for ganglion. There was no morbidity, but and mortality was 2, among which 1 was male and 1 was female. Mortality: 68-year-old lady came in emergency with acute retention of urine with shortness of breath. She was known diabetic and had CKD. She was known case of endometrial carcinoma with metastasis to liver. She had received radiotherapy and chemotherapy earlier. She was catheterized and managed conservatively, but succumbed to death because she was not maintaining saturation. She was we tried to manage it, but after 3 hours of admission, she died. Mortality: 2. 78-year-old male came in emergency with abdominal distension, constipation, and with features suggestive of large bowel obstruction on X-ray erect abdomen. Patient was planned exploratory laparotomy, but patient had shortness of breath and not maintaining saturation on oxygen therapy. Patient was shifted to ICU, but finally succumbed to death. Thank you.
Omkar, regarding the second case, what was the vital status on admission?
Sir,
case?
yes. Sir, patient saturation was sir, 60% around 60%, sir, on admission, sir, and
You see, the most important part of management
sir, your sound is not audible. Voice is not audible.
Sir, you're not audible.
patient is a good resuscitation. Think of doing a laparotomy. Okay, but unstable. So the primary specialty code for MT.
Sir, sir, your voice not.
Hello. Taha sir, your voice is not audible.
The first case is advanced malignancy. The second case, here the patient should be. What fluid you started for this patient?
Sir, normal saline.
Normal
Yes.
saline. Then, how much saline you have pushed? 78 years, gentleman. These are all important. On admission of an elderly gentleman with hemodynamic unstable, you have to know the correct fluid to be given, how much to give, and how to monitor this patient. This patient was in ICU straightway.
No, sir. First admitted in ward, sir. But
Yes, the other patient who should go to ICU. The other patient who should go to ICU. Okay.
sir, there was sir, after admission, sir. After admitted in ward, patient went to ICU. Patient was sent to ICU, sir. After sir, approx 4-5 hours, sir.
Okay. 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 Siddharth, you can continue discussion for some cases. Okay. I will be coming. Okay.
Yes, sir.
I will be coming for operation. Continue discussion for some cases. So, Milind, I'm leaving. Huh? Okay.
Yes,
Sir,
Yes, sir.
thank you, sir.
Thank you, sir.
Thank you, sir. Okay. So you these are the only two mortalities. There were no morbidity on your part during the last one.
Sir, your voice is not clear, sir.
There was no morbidity on your part.
No, sir. Morbidity.
Okay. Okay. Thank you very much.
Yes.
Let's conclude the.
Thank you, sir.